you very much, and thank you for inviting me to speak. So I'm going to speak a little bit more broadly about cannabis and MS. And the first thing to say, actually, is I have not accepted any fees or expenses from any cannabinoid companies. I don't do private practice, so I don't palm off cannabis on the side to my patients. And if you've ever seen me in Oxford on a bench with my mate Bill, I did not inhale. So I want to go through a little bit about cannabis, how it works, what we use it for, and how it's used in MS. I want to talk a bit about what the law says, because I think this is really important to get clear in our minds, and also what NICE says, because we all prescribe inside NICE guidelines, or the Scottish guidelines, or the Welsh guidelines in our case. So then I'll come on to talk about our experience of Sativex in Wales since 2014, and then also what our patients think about cannabis in general. So what is cannabis? What's in it? So cannabis is a really, really complex plant, as you're all aware, and it contains, over 400 different chemicals, 80 different cannabinoids, and every plant that's cultivated is slightly different. So you can cultivate plants to be really high THC dominant, which is really good for the black market. And then you can cultivate plants for medicinal use more, which are fully CBD. So if they're less than 0.2% THC content, then that's legal to grow, although I have to just warn you that you still do need a Home Office license for this. So if you're caught with cannabis plants in your house, you can't just say, oh, they're fully CBD. It's okay. So the THC and the CBD are the two main compounds that we think about with cannabis, and it's the delta-9 tetrahydrocannabinol, which is the one that people are very interested in, that has all the psychoactive properties, but also a lot of the properties that we use for spasticity, the muscle relaxation, and some of the anti-analgesic effects. So THC is a partial agonist of the cannabinoid receptors in the brain. And there's two main cannabinoid receptors, CB1, which is present in various different parts of the brain, and is probably the one that you're interested in if you're thinking about anti-spasticity agents. But then also it's an agonist of CB2, which is present in some of the immune cells, which is also why it's interesting in MS. So then CBD is an antagonist of these receptors in the presence of THC, which is why when you have a plant, you do need to have some CBD in there to counterbalance the THC and some of the psychoactive properties of THC. But also, CBD more complexly acts on a lot of non-cannabinoid receptors throughout the body, particularly those present in immune cells, which is why it has some of the anti-inflammatory properties that we'll discuss. So does it work? And what does it work for? So there's a lot of interest in MS about the anti-inflammatory and neuroprotective properties of cannabis. And there's a lot of work that's gone into animal models using CBD, so the experimental model of EAE, allergic encephalomyelitis in mice. And they've looked at CBD and shown reduced inflammatory infiltrates, prevention of demyelination, possibly some increased remyelination, and reduction of all of those oxidative protein stresses and the neurotrophic factors. So there's definite animal model evidence that cannabis may have, and particularly CBD, may have an anti-inflammatory and neuroprotective effect. But the problem came with the CUPID study, which was very much a pivotal trial run from Plymouth, that looked at oral THC in MS patients with progressive disease. And it quite categorically showed that there was no benefit for patients on disease progression or atrophy. And this is a bit of a problem, because when a lot of kind of non-pharmaceutical money has been invested in a trial which is definingly negative, it's very difficult for the funding bodies to go back there. And so I think this really has stop trials looking at this subject, but there were a few problems with this trial. The first being the drug they chose. So dronabinol is a synthetic oral THC. And so, as I've just discussed, a lot of the work in EAE, the experimental model, is of actually CBD. So you're suddenly missing out all of the good properties that you might have got from CBD by using this drug. And then also, for anybody who did the CUPID study, it was not double-blinded. The patients took the THC and they knew it. There was no hiding behind a placebo. So it was slightly flawed in that manner. And then the other problem with oral cannabis is that it's got a really high first-pass metabolism in the liver. So if you take it orally, a lot of it is metabolized, which is why people inhale cannabis. Because you get a sudden and very steep curve and it all goes straight to the brain. So I think for those reasons, it may have impacted on the trial's results, but I'm not sure we'll be getting any future trials in the near future anyway of cannabis looking at this question, which might be a shame. So what other things do we use it for? Well, the patients really like the idea of using cannabis for pain. And certainly, the patients report to us, a lot of patients do report CBD or cannabis is useful for pain. But what do the trials say? It's really actually very difficult conducting trials in pain because your outcome measures are always subjective. And so there's a high placebo effect in any pain trials. And the other problem is that cannabis is very heterogeneous. So when you're trying to look at the global amount of trials done, they're all different products that were used. And pain is very heterogeneous. So you all know that neuropathic pain is very different from muscular pain. And that's often very difficult to tease out for a clinical trial. So actually the Cochrane review that looked at neuropathic pain and the use of cannabis for neuropathic pain showed that the number needed to treat for a 50% reduction in pain was about 20, whereas actually the number needed to do harm, so for significant side effects, was much, much lower than that. So that's why it's not recommended for pain, because it's just not been shown to be beneficial in the clinical trials. So when looking at spasticity, as you know, it's taken a long time for Sativex to come through for spasticity. And that's because, again, the trials were difficult to conduct. And there's been a few trials of Sativex looking at spasticity. But we have shown that it works for some, if not all, patients. And so about 50% of patients in the trial benefited from the Sativex, and that could cause about a 20% reduction in spasticity. So you can see, I've just put this image up because I think the trial was conducted eventually in a clever fashion, in the fact that they gave all of the patients the Sativex in a single-blinded fashion for the first few weeks. And so you can see that reduction in spasticity is quite dramatic at that phase. And then they double-blinded it, so they split people onto either the placebo or continuing on the Sativex. And so you're kind of getting rid of a lot of that placebo effect by doing the trial in this manner. And you can see the reduction from the top line to the lower line, a significant reduction in the amount of spasticity that's shown. And that's what really the licensing companies are looking at. So what does the law say? So just to remind everybody, despite what the media thinks, cannabis is still a Class B drug. So that comes with a 5-year imprisonment for possession, potentially, and up to 14 years for supply and production. So I think we just need to keep that in mind when we are talking to patients about cannabis. So the exceptions to that are the very low THC products. So that's why you can go down to Swansea Seafront and go to the Cannabis Cafe and have your milkshake or your coffee because it's less than 0.2% THC. And of course, you can buy hemp and CBD oil. A lot of the patients are buying over the internet. So what's really important to remember about that is, first of all, you need a Home Office license for cultivation for low THC plants. And also, I always advise patients who ask me that when they are buying CBD oil, these products are not MRHA regulated, which means that they aren't pharmaceutical grade products. And when a study's been done looking at actually what is in the product, it's often different from what is on the label. So there just needs to be a certain amount of caution with regards to advising your patients, because we often get asked for our advice about CBD, don't we? And so I say, look, you just need to be careful. I'm not going to tell you you can't do it, but this is what these studies have shown. So the other exception is the CBPMs, or the cannabis-based products for medicinal use in humans. So this came into effect with much hurrah in the media on the 1st of November 2018, and we all suddenly got the phone calls asking if we could prescribe the cannabis for our patients. And so then when you drill down to what that actually means in the fine detail, the cannabis-based products for medicinal use specifically cover cannabis and cannabidiol, which are produced for medicinal use, so they have to have their MRHA approval, and are medicinal products, so a pharmaceutical grade. They have to be supplied by specialist doctors, and companies wishing to possess, supply, produce, manufacture have to have a Home Office license for it. And so that restricts us to not prescribing cannabis willy-nilly for our patients. And as we've discussed, we all prescribe under guidelines. So what does NICE say? So the NICE guidelines were published in November 19 and then updated more recently. And there's quite a defined pathway for prescribing cannabis. So first of all, what cannabis-based products do NICE talk about? Well, these are the products as if in the regulations, as we've just discussed, and they specifically refer to Sativex and Nabilone. Nabilone being a drug used for chemotherapy use, nausea and vomiting, and then plant-derived pure CBD products, and then synthetic compounds such as dronabinol. So when you prescribe, it's important that you have a shared care agreement with the patient, and then after you've prescribed initially with the GP. And that's to make sure that there's been a formal discussion with the patient and special considerations are taken into account, such as driving and travelling. You can't just take your Sativex on an aeroplane to the Middle East. It's not a good idea. When you do prescribe, it's really important that you're a specialist medical practitioner and that you have an interest in the specialty you're prescribing for. So I do not prescribe for epilepsy, Epidiolex for epilepsy. I leave that to the specialist epilepsy doctors. Even though I see quite a few people with epilepsy, I think if it needed to go up to that level, I would send them on to the specialist epilepsy clinic. And I think the same is it with multiple sclerosis. It shouldn't be prescribed by general neurologists. It should go to the specialist centres for MS. And then you also need to consider, and this is all in the NICE guidelines, you need to consider their past use of cannabis, any other illicit substances they've used, and then their other past medical and, importantly, mental health history and drug history to ensure there's no interactions. So all that's really important, but when it comes to the nitty-gritty, what can we actually prescribe it for? What symptoms can we use and what products can we use? Well, chronic pain is the first thing mentioned in the NICE guidelines, and they quickly disband this because there's no evidence for it. So you can't prescribe for chronic pain. Chemotherapy-related nausea and vomiting, so discuss Nabilone, which is prescribed, and then dronabinol, which is only licensed in the US and in Germany. So then intractable epilepsy, we have Epidiolex, as we've discussed, which is pure CBD, and then Sativex for spasticity, which is clearly what we're interested in. So it's really very, very well-defined and narrow prescription guidelines from NICE. So coming on to spasticity and Sativex. So this is a little bit like when Wales wins and beats England in the Six Nations, you know. and there's a big hurrah from over the border. Sometimes it is fortunate to be living in one of the disbanded nations. So we now have access to famotidine as well, which we've recently had approved by the All Wales Medicines Committee. Sativex still isn't approved in Scotland. So a little bit behind the curve there, I believe. So the prescribing guidelines in England given are very similar to those in Wales in that you have to have a 4-week trial of Sativex, and you have to have ensured that other pharmaceutical agents for spasticity have been trialled, so baclofen, gabapentin, clonazepam, etc. And then you have to have evidence that after that 4-week trial, there has been a 20% improvement with spasticity. So this is really important to remember when you're setting up your guidelines and your pathways for prescribing Sativex. So I just want to talk to you a little bit about our Welsh experience. And just to disclose, the Sativex is run mainly from our neurorehabilitation centres. So we encourage them to set up they run all the spasticity services in Wales through neurorehabilitation, and so they were well placed to actually set up the prescribing of Sativex from there. So a lot of this data I'm sharing is from Dr. Javid and Elise Church, who run the service there. And we found it useful to set up a patient pathway for the prescription of Sativex, which initially involves an MDT assessment with neurophysio, to look at the spasticity, to assess triggering factors, and to look at other oral medications that they've used, whether it be baclofen or clonazepam for those nocturnal spasms, gabapentin if they've got lots of neuropathic pain as well, sometimes tizanidine, although I must say I find the monitoring requirements of tizanidine somewhat difficult, so it does put us off the prescription of tizanidine a bit. So then, if the patient's failed with these drugs or not fully controlled with these drugs, unless we've deemed them suitable for a trial of Sativex, they'll have baseline bloods done. We have an information leaflet that's given to the patient. So that's part of this patient joint care experience, making sure that they are aware of all of the potential side effects and the fact that they are using a cannabinoid product. And that details things like driving and travel. The patients are advised not to drive during their trial of Sativex, because if you have side effects from Sativex and you're found to be not in control, it's very much like some of the benzodiazepines. If you do drive when you're not fully in control because of a drug, you're liable for that, so you're not insured and you can be prosecuted. So that's important for the patients to understand. And then the outcome measures. So different centres in Wales use slightly different outcome measures, but I don't really have a great preference. It's essentially what your centre finds most useful, whether the NICE guidelines specify that you need the 10-point scale, but also using other spasticity measures that patients can do at home, so PROMS, spasticity questionnaires, spasm frequency, quality of life, things like that can be really helpful. And so the Sativex prescription is via a specialist, and they have a 4-week review with repeat outcome measures to assess their response to the Sativex and to discuss any side effects and review their other medications. So commonly other medications can be titrated down once they're established on Sativex. And then at that point, if everything's kosher, we can pass their care on to primary care with, again, a shared care agreement with the GP. We collected some audit data from some of the centres in Wales up to 2018. I must say it's been somewhat trying to collect audit data in the last couple of years, as I'm sure you'll all attest to. So I don't have more updated data to hand. Or not all of it anyway. But just to look at the Swansea data, because I'm most familiar with that, from 2014 to 2018, 68 patients had a trial of Sativex. So that's not a vast number of patients, and it probably reflects a slight slowness of starting the service and setting up the pathways for that. 10 of those patients couldn't tolerate the drug, and 5 found they had no benefit at all. So of the 53 patients who completed that initial 4-week trial, over the following year, another 17 stopped. A couple died, but for non-Sativex related reasons. And then others just found that the side effects or the benefit wasn't quite to their liking, so discontinued. So that's about a 53% response rate, which mirrors the clinical trials. I think Cardiff's experience has been somewhat similar. Their response rate was slightly higher, but I think their data was slightly shorter as well. So it's probably just that a lot of the patients hadn't had it for very long. So I expect they've had more dropouts since that time. And North Wales, again, similar figures. Cardiff didn't start till 2016 because they did have quite a lot of problems with the setup of the service and just getting the funding to suddenly see all these patients at week 1 and then at week 4 with a physio and the questionnaires is actually quite tricky to get the infrastructure around that. So this is a subjective reports from 116 questionnaires, which are more recent. So as you can see, we've had more people come onto Sativex, and this is from a recent survey from February of this year in Swansea. And about 70% of the patients say they have a reduction in spasms. It's interesting, quite a few patients report improved sleep on the Sativex, and I think a lot of that is because of the reduction in spasms at night. Some people report being able to get rid of some of their other medication as well. Not many people report reduced pain, which does kind of follow through with that, the trials of cannabis for pain. So just a few tips from our experience for prescribing Sativex. You don't necessarily need the full amount. Very rarely do patients need the full 12 sprays a day. And sometimes just 2 sprays a day is enough just to control their spasms. And actually, because the side effects are somewhat dose dependent, it is worth trying lower dose. So if patients experience hallucinations on the higher doses, it is sometimes worth just dropping that down a bit. As I've said, we do give them driving advice, and for some patients who are affected by the Sativex and still need to drive, it's worth considering just nocturnal use. And it's important to note that it is, we've had a couple of patients come into relapse clinic after starting Sativex because they feel their legs are suddenly weak and they're falling a lot. So you may need to titrate down other agents like baclofen and just keep mind to that. It's really important to look for patients who have a history of substance abuse because they're much more likely to abuse Sativex, so be aware of that. And they do need specialist, experienced physician guidelines. How am I doing for time? Okay, so just quickly what the patients say. The patients who try it and it works for, really like it. And these are some of the feedback we've got about Sativex. And for some patients, it's a really, really revolutionary drug, lets them get out of the house and do things that they haven't been able to do before. There's studies of kind of use of cannabis or marijuana in different places. So this is a study from the USA of about 5,000 people responded to the survey, half of which lived in states where marijuana was legal. And there is kind of a big surge from patient groups to legalize marijuana because they feel that it's beneficial. And so we just need to be really aware of that. We did a small study of our patients at a face-to-face meeting we did pre-COVID for patients with progressive disease, and we just asked them to fill in a quick survey about cannabis. So we got quite a global response from a non-biased group of patients with secondary progressive disease, and I was surprised at how many people had tried cannabis, a lot of it before even they were diagnosed with MS. Only 10 of the patients were still using a cannabinoid, and most of that was CBD oil. So there weren't many people in this group of patients who carried on using cannabis, but you're all aware of patients who come into clinic and admit to cannabis use, and I do ask them openly about it because it's also important for the tobacco content of the cannabis that's smoked, which is important to counsel them on. So just a few key points. Cannabis clearly has benefits in MS. A lot of our patients use it, and the patient perceptions of cannabis are very different from the clinical trials. So it's important that we as healthcare physicians know the law, know the guidelines, know what we can prescribe it for safely, and just make sure we're open with the patient. So I always ask patients about it in a very non-judgmental fashion, but then just give them guidance about potential detrimental effects. And we just need more research into the subject. So we often have to say this to patients, and we're not the ones who, well, I'm not the one who's conducting research into cannabis because it's actually quite difficult to fund, and that's the problem. And no pharmaceutical companies are funding cannabis research, so it's kind of stagnated there, which unfortunately for patients is detrimental, because I think there's potentially lots more to gain from it. So thank you for listening. I'm happy to answer any questions. I'll just acknowledge, as I say, the teams in Cardiff, so Dr. Lohman and Rihanna Hallahan, and our rehab team, Dr. Javid and Dr. Church, who've shared their data with me, and my physiotherapist, Lynn Watson, who's got an interest in this subject as well. So thank you.